So anyway, so let's, I guess let's get started. I'm going to probably try to switch over to the other computer as we're talking, but I'll get started anyway. So thanks for everybody joining tonight. A lot of things going on in the world of prostate cancer and also in the VA. With VPCA, we've been briefing and introduced our new software technology. Veterans Prostate Cancer, or it's actually Prostate Cancer Health Storylines, and we've got a number of commercial applications, or a number of commercial places that are going to be installing it. One is in Dallas and Oklahoma City. Another is we were just in Palm Springs yesterday. So Halo DX, we're going back to brief their entire urology group there for Southern California, and so we're hoping that that's going to go well. I think it will, and then we're also looking at installations in the VA. One of the things about the VA, so everybody is aware, one announcement is there's a program called Mission Daybreak. It's a $20 million suicide awareness and suicide prevention or intervention program. They're looking for new technologies or innovative technologies to help with the suicide programs and suicide problems. We were asked by a couple of undersecretaries to submit our software program for that, for the application, and we've done so. There's a component inside of it that is called the mood tracker, which was developed in conjunction with PTSD patients and guys that were distressed, but also the theory was that they wanted to have an immediate link back to their physicians and back to the clinics, and that's what this software provides. Is there's a portal that if you can actually track, the physicians can track how they're doing with the response every day, or they don't respond every day. You can intervene, and you can call them directly through the software and do a FaceTime video with the guy and talk to them. And the psychiatrists that we've worked with have all said that the biggest issue is time to intervention, not so much how you intervene, but actually how you intervene. It's so if you're able to get to a guy when they're in that crisis moment, you can actually start to save lives. So it's we're hoping that we're down selected. We'll know in September, and obviously make the announcement. We'll make the proposal available to everybody that's on the call, and I think we'll post it. Maybe we'll put it on the internet, and we'll let guys take a look at it, both physicians and anybody else that's interested from a clinical space. And please, we're looking for comments, looking for anything else that anybody wants to join in and make comments to it. Please, you want to try it if you're a physician or you have a clinic, we'll make sure that you have access to it. Next is the biggest plans coming up are in September, the end of September. We've contracted for a chalet at the Miramar Air Show. It's 23 to 25 in San Diego. Everybody on here is invited. It's 3-day over the weekend. It's the first time they've had an air show since 2019. And the reason we're going is for two things. One is to actually recruit members or recruit former military aviators with prostate cancer into our clinical study. But the other is to just raise general awareness around the fact that vets and prostate cancer, right? So they're expecting to have 1 million people attend the air show over a 3-day period of time, and because it's their first one that they've had in a number of years, they're expecting a really good turnout. They've had a really good sign up for this whole thing. There's a lot of people already buying tickets and that sort of thing. It's actually nice because my son happens to be the operations officer at Miramar. He's a lieutenant colonel in the Marine Corps, and he runs the air show. So we get some preferential treatment. We get a couple of extra golf carts to drag people around and that kind of stuff. So it should be fun. And I know Terry is on the call, and actually, hopefully we can recruit a number of guys to come out for a little mini reunion and that kind of stuff, and use our chalet. So we'll get guys to sign up, and we've got a lot of interest from our sponsorships or our sponsors out there. So yeah, we're looking forward to it. So that'll be September's deal. A lot of physicians are being invited, a lot of VA senior members of VA, a lot of leadership have all been invited. So we think that we should have a nice showing of people, again, providing that venue for industry and veteran leadership to actually have the discussions, away from the press, so people aren't watching them and that sort of thing. So yeah, it's good. And that's really it. And we're getting into the fall where we'll have some more back in DC. We've got some the Air Force Association annual convention, and also the Army USA show, and then followed by our Veterans Day event on board the USS Intrepid in New York City. And that kind of rounds out the year. So for that, I'm looking to see on my thing if Sarah is here. Is Sarah Gilbert here? Yes, she is. Hi, Sarah. So the floor is yours. Our biggest question is, give us an update on 4880 and 2720. And I'm going to see you on Thursday, but look forward to seeing you. But let us know, what can we do? We're going to, I think, the letter campaign or whatever, but I don't want to steal your thunder. So how are things on Capitol Hill?
Well, things are busy on Capitol Hill. Thank you for having me. I appreciate it. And, I don't have a huge significant update from the last time y'all invited me on, which was, gosh, a couple months ago, I think, at this but, what I'm told is that there's a room for a package of VA bills to move this year. I'm told the package already has a name. It's going to be referred to as the Dole-Cleland Act. I don't know what else is anticipated to move in this bill. I think mental health related provisions. But I think, what we really need from the community and from you all, from our stakeholders, is that outreach to the House Veterans Affairs Committee. So Chairman Mark Takano, California, Ranking Member Mike Boss, Illinois, Chairwoman of the Health Subcommittee, Julia Brownlee. She knows about this bill. She and my boss served, across the dais together. He was chairman of that committee several years ago. And Jack Bergman, Michigan, is the current ranking member of the Health Subcommittee. So just want to keep the pressure on. I think, the House floor schedule is being driven a lot right now by what the Senate's doing, which is a lot over there. A lot going into maybe reconciliation again. We've got this CHIPS bill, but I think what the good news is that the Senate VA committee is not really being pulled into those conversations too much. So I'm told that they are kind of marching forward and working to get a product out that can move this year. So, really just I want those members to hear from constituents, to hear from veterans, to hear from those that care about prostate cancer and care for those, living with prostate cancer. So that's about all I got. I hope to have more, solid information, such as, what that package actually looks like, or committee activity. The good news is this bill passed the House last Congress. I don't think they'd put it through a strict committee process again. I think it's more or less greased to go straight to the floor when the powers that be decide that it can.
That's great, Sarah. So we just a quick update for the crew here. I did speak with our compatriots at Wounded Warriors today. We've been pushing through what they call the TACT Act, and they just it's going to what they call cloiture today, I guess, or I think one of senators, I think Schumer nominated or pushed it through today or whatever. So we all were writing letters. Wounded Warriors, the reason I'm bringing it up is that we're going to start a letter campaign probably in the next week, and stay tuned for that. And we'll ask you all to just go online, and there's going to be a link where you can go online, just put your address in, and then it'll have a letter that will be sent to all your senators and congressmen, the appropriate people. And that letter will have Sarah's phone number in there, so that as the sponsor of the bill, she'll be receiving, everybody will know who to contact when we do this whole thing. So stand by for that. Look forward in the next week or so, and the Wounded Warrior guys are in the Teams Coalition. Excuse me, are all signing on to help us out, to help get this over the hump. And so we appreciate everybody's support, and just look for that. So Sarah, we'll talk to you Thursday about the details around that, but everybody's signing on to help us, carry the heavy lift here. Okay, next is our guest speaker, Amanda Beserra. So Amanda, I'm going to let you introduce yourself, and everybody's very excited about the technology that you're going to chat about. Clearly, it has a direct impact on a lot of us that deal with prostate cancer and those early diagnosis and other treatment options. And so with that, I'm going to turn it over to you and I know that you just came from procedures, so there's not a lot of study that you have to do. So floor is yours.
Sounds great. Let me share my screen. Perfect. So I'm Amanda Beserra. I'm a senior clinical scientist at Profound. I've been with the company since 2019. I travel around the country to support procedures, also work on product development, as well as increasing the amount of clinical publication. So in the next 20 minutes, I'm going to go over a little bit about what's the TULSA procedure, a little bit about our clinical data, what a typical TULSA procedure day looks like, and some real-world case studies showing the flexibility of this procedure. Okay, so in the current prostate cancer therapy space, we see a common theme when we look at the two technologies most commonly used and how they have evolved. When we look at the direction of their evolution, what we see is that robotic inclusion is about imaging and looking to reduce the number of incisions. Radiation is also about improving imaging as the years pass by, trying to improve precision and reduce the number of treatment sessions, since we know that radiation is generally difficult to control and does not discriminate between healthy and unhealthy tissue. Well, TULSA is foundationally about imaging and the best soft tissue imaging technology, the MRI, where we can see the details, and TULSA uses heat to impart the Q effect in the tissue, which is one of the safest way to avoid any long-term effect on healthy tissues. These two technologies combined with advanced software control robotics really gives us the capability to precisely deliver treatment where it's needed and spare some vital parts, which are important for sectional and urinary function. So here you can see an illustration of our TULSA procedure. We have an ultrasound applicator inserted into the urethra, this soft Q-day chip ending to the bladder. As the procedure is happening, we have our urethral cooling, which is giving us 2 to 2 millimeters of urethral protection. We also have a rectal cooling device, which allows us to cool the rectal as we are ablating the prostate. That combined with our MRI-guided planning, as well as real-time control of the temperature, has led to a very safe safety profile, which I'll share in the clinical data. We haven't had any rectal fistula in our procedures, both on clinical trials as well on commercial treatments so far. So here what you can see, here we have a section of the prostate. So cutting across those ultrasound elements, we see the ultrasound applicator sending this blade of energy from the urethra towards the edge of the capsule. The way that the procedure works is that we are monitoring the temperature. So we get a new image every 5 to 6 seconds when we are inside the MRI, and we use that image, that thermal map, to determine the driving conditions of the ultrasound applicator. So we can ablate prostate tissue with about 1 millimeter of precision. So as you can see here in this illustration, we have 12 glands across the prostate for 10 of the ultrasound elements who are delivering that thermal energy and 2 monitoring the apex and the base of the prostate. So we're sweeping from the urethra around the prostate, delivering that thermal image with precision in a controlled way. The treatment planning is done using live two-dimensional imaging as well as diffusion images, which are essential parts of MP MRI. So there is no registration. We are not taking baseline old MRI images, importing to a software. So we acquire images with the device in place. Here you can see the ultrasound applicator, which is coupled to a robotic positioning system at the MRI table. After those devices are inserted, as you saw in the animation, the patient moves into the MRI bore. Those devices are connected to a positioning system interface box, which controls the cooling device as well as the system electronics that's driving the ultrasound applicator. Every 5 to 6 seconds, we are receiving one MRI thermometry image, which is a thermal map of the prostate. Based on that thermal map, then we calculate what are the parameters required to drive the ultrasound image, feed that information back into the system electronic in that closed looped fashion. So it's an automated thermal modulation control. So when we look at that temperature every 5 to 6 seconds, our software is automatically determining what's the rotation rate of the device rotating within the urethra, what's the frequency of each one of those ultrasound elements, which indirectly determines the distance that we travel from the applicator, and what's the power for each one of those independent ultrasound. So in terms of the workflow, in the beginning of the procedure, we just have an equipment set up where we do a quality assurance test of all of our robot, as well as a test of our ultrasound applicator. Then we have a patient preparation, which includes some parts outside of the MRI room where the patient is getting the IV placed, and some sites being anesthetized outside of the MRI. Then the patient moves inside the room where the ultrasound applicator is placed, as well as the endorectal cooling device. When the patient moves into the bore, the physicians do the treatment planning outside the control room based on real-time MRI images. So they perform the alignment of the device using three-dimensional images and a detailed planning of the intended ablation zone. So here you can see that we are demarcating the entire prostate. But with this technology, we can achieve a variety of treatment plannings, which I'll show you in some case studies. So we can go from a whole gland ablation to a very focal ablation, depending on the patient's and the physician's preference. During treatment, we are actively monitoring the ablation, and the physician intervene as needed. Maps that are displayed every 5 seconds. Then after ablation has been performed, we confirm the ablation extent using a contrast-enhanced optional MRI image, transfer the patient forward to recover after the device were removed, and that equipment setup then gets prepared for the next patient. When we look at the clinical data timeline from where we got until the point we got now, the technical development really began back in 2000, which then led to the formation of the company in 2008. We had our first human academic studies where patients underwent radical prostatectomy immediately after TULSA, and we used that histology data to register to MRI thermometry, which it was then when we were able to determine that we had an accuracy of 1.5 millimeters between the ablation plan and the histological region of cell death. Then we had our phase 1 trial completed in 2015, which was a safety and feasibility study. We then target 90% of the prostate, and as expected, we achieved a 90% of PSA reduction, as well as 90% prostate volume reduction. Now we have a 5-year follow-up from that data, which demonstrate really durable and predictable outcomes with stable quality of life. In 2017, we had our TACT pivotal trial, which was our FDA registration study. So that was a whole gland study, primarily patients with intermediate risk disease, 63% of them, and we'll review a little bit about the outcomes of that trial. Once we got the 1-year outcomes from that trial, we had our FDA 510K and Health Canada clearance in 2019. In 2020, we started the clinical adoption. So it's commercial procedures here in the US. And just this year, we launched our randomized captain trial, which we are comparing TULSA against radical prostatectomy. So across the spectrum of prostate diseases, we have a number of publications that really shows the flexibility of TULSA, treating different treatment plans, different indications. In terms of prostate cancer, all that data has been consolidated on our systematic review, which I can forward you that publication afterwards. Within that spectrum, we see patients with low risk to high risk, intermediate risk disease. Patients have a customized ablation hemi to whole gland, also some evidence on the salvage setting, and as well as patients with symptomatic BPH that did not have a diagnostics of cancer being studied, or those are publications from Europe. So to talk a little bit about our TACT trial, which was our FDA registration study done in partnership with FDA. So it was a study with 115 patients across 13 clinical sites in 5 countries, men from 45 to 80 years old. Majority of those patients had intermediate risk disease, 67% of them. What we saw in there was a median PSA reduction of 95%, which was stable to 3 years. 80% of the patients experienced histological benefit. So they had reduced cancer grade volume with extensive biopsy sampling. So we were, all patients underwent 10 course biopsy, and the average prostate size was 3 cc. We had a median prostate volume reduction of 92%. So, you know, in the post follow-up setting, typically physicians are sampling 1 core per 3 cc. We were sampling 10 cores per 3 cc. So in anything really that was in there was very likely we found. Now at 3 years post-treatment, 13% of men underwent additional intervention, which is really comparable to acceptable rates of relapse after a standard prostate cancer treatment when we compare to some previous trials. Here you can just see on the right side an example of the prostate looks like from screening. It was a prostate that started at 58 cc. Immediately after post, you can see the zone that underwent acute thermocoagulation, shown in black. 3 months post-treatment, the prostate has reduced in size, and PSA is already below 0.1. 12 months post-treatment, we see that cavity here taking most of where the prostate was located, with a prostate of 0.5 cc's. So that trial was a whole gland study. We didn't allow any sparing of ejaculatory ducts or neurovascular bundles. So even though our technology was able to provide that customizability, was a whole gland study. So to share with you some real world experience, this is a study from, it's a publication, clinical report from a private radiology clinic in Germany. So those are their first 52 patients, 47 with primary prostate cancers and 5 coming from a salvage setting. Most of the patients had intermediate risk disease, but unlike the TACT trial, we did have a percentage of patients with high risk disease. 80% of the patients had a partial gland ablation. 75% of them had 1 or 2 nerves being spared, and about half of those patients were being treated for both a focal prostate cancer lesion and the bulking of the transitional zone for benign prostatic hyperplasia symptoms. What we saw is a similar safety profile, only 2 patients requiring an endoscopic resection of residual tissue. And 1 patient from that cohort was wearing 1 pad at night. All patients that were fully potent at baseline, they remained at the last follow-up as well. The follow-up in that study was driven by MRI and PSA. 73% of those patients had a negative MRI and no PSA failure. From the patients that did have some residual disease, out of the 14, 9 of them had a biopsy. From the ones that had a biopsy that was positive, they had a TULSA procedure, and follow-up was available for 8 of them. All of them had negative follow-up and very low PSA, which then brought that This is success to 88% of having a negative MRI and low PSA after the repeat TULSA. From the patients that were seeking the booking of BPH, we saw that 83% of them had improvement of urinary tract symptoms, and all patients that were taking medications for lower urinary tract symptoms before the procedure discontinued the use it after that. In terms of SAVAGE, this is a small study was published in European Urologists from one of the European sites, which is a preliminary report on 11 patients, which is a phase 1/2 study in 40 patients that they just finished treating. Will be publishing the full outcomes soon. What we saw in there at 1 year MRI, based on MRI, PSMA, and biopsy, one patient had an in-field recurrence, 2 patients had out-of-field recurrences, and no biopsy recurrences were visible on MRI. There was minimal change in quality of life, both urinary and sexual function. It was a very promising safety profile, especially since, those prostates have been through a lot after radiation. There was only 1 urinary retention, which was resolved after dilation, and 3 retentions that require recatheterization and antibiotics and were solved afterwards. So here in this example, you can see a case study from that trial where the patient had a radio reoccurrence, grade group 5 on PSMA PET. On the right side, then he had a SAVAGE hemiablation here, and everything that you can see in yellow has reached at least 55 degrees Celsius, yellow and green. So that's the temperature our controller is looking for to achieve thermocoagulation and cell death. Then you can see the areas that underwent acute thermocoagulation, and 1 year post-treatment, that patient had a negative biopsy, PSA of 0.34, and a negative PSMA in there. So I talked a little bit about our systematic review. That's where we consolidate all of our data on prostate cancer studies. So we're reviewing 10 studies where 224 patients were treated with TULSA for prostate cancer. Because a lot of that trial is coming from the TACT trial, we do see that most of the patients had intermediate risk disease. 6% of patients in that cohort having high risk disease. Smaller cohorts for recurrent prostate cancer, locally advanced prostate cancer combined with lower urinary tract symptoms relieved, had a median follow-up 1 to 2 years, maximum of 5 years. And one of the outcomes of that review, which is a level 2A evidence, was the modeling of the SAVAGE and potency as a function of the planned ablation fraction. So you can see here on the x-axis is planned ablation fraction. So how much of the prostate the physician included in the plan. And then here we have the SAVAGE free rate. So how many patients didn't require additional treatment? And here we have potency preservation. So how many patients continue potent after TULSA procedure. So what we saw is that the more we ablated, the highest was the SAVAGE free rate. And that followed a linear relationship. And you see here in light blue, it's the TACT study. It was our FDA mandated study. And then in terms of potency preservation, we saw that sigmoid relationship where we have pretty much, a flat curve as we get to that 85% planned ablation fraction. And we do have a small decrease as we go towards that 100% planned ablation fraction in there. We saw a PSA reduction across all indications between 54% and 97%, since we're going focal to whole gland. 6% grade 3 complications, which require additional intervention. No rectal fistula. 3% of the patients had infection. 1% stricture. 1% had a retention. Highest occurrence of an adverse event was a grade 2 urinary tract infection, 29% of the patients. And remember that both in the phase 1 TACT trial and that Lumiani study, there was a suprapubic tube placed near the MRI. For primary prostate cancer, we saw that 10%, range 7 to 17% of patients had a SAVAGE treatment by 2 years. 92 to 100% of patients were completely PAD-free. and 75 to 98% of patients kept erection firmness sufficient for penetration. In terms of urinary symptom improvement in a combination treatment, 85% of the men had an improvement compared to baseline. This year, we've launched our CAPTAIN, which is our randomized trial of TULSA against prostatectomy. It is a whole gland study with minimal sparing nerves, ejaculatory ducts, and sphincter when appropriate. We're recruiting 201 men with localized intermediate risk prostate cancer. We started recruiting in January. Is a 2-to-1 randomization. So 134 patients are going to go to the TULSA arm, and 67 are going to go to the prostatectomy arm. And we're using a couple of indicators to stratify that: potency, continence, risk, age, PSA, and histological grade. So we can keep the two arms balanced. In terms of outcomes that we are hoping to achieve at 1 year, safety, our goal is to be superior to prostatectomy in terms of the percentage of patients maintaining continence and erection. And at 3 years, we hope to be non-inferior to prostatectomy in terms of the percentage of patients with no additional interventions, meds, or death. It's a long study, so we are following those patients for 10 years and looking at survival, complications, PSA, medications, and quality of life. So I talked a little bit about how in 2020, we started our commercial programs in the US, and then I'm gonna go over a little bit about a couple of case studies that were done in an outpatient procedure, so either hospital imaging center or an independent imaging center under general anesthesia or sedation. Patients can have a Foley or suprapubic catheter. And when we are in that space, there is really a variety of treatment plans that the physicians can perform that's truly customized to the patient's disease and needs in there. So the first case, which is a courtesy of Dr. Cianci, it's intermediate risk cancer with dose escalation. So this patient had intermediate risk disease. And here on the left side, you can see just sketch drawing that the physician drew with the patient. So we have an MRI visible lesion on the patient's right. So he planned here to escalate the dose, so treat that area twice when he were ablating, preserve the bladder neck, so no thermal dose being deposited in there, as well as preserve the left neurovascular bundle by, sparing that area close to the NVB. Here on the right side, you can see the thermal dose that was achieved for that plan. So anything in yellow has reached a lethal thermal dose. So there is preservation of the left NVB as planned, the bladder neck has been preserved, and extra dose deposit next to the index lesion. The next case study, it's a high-grade prostate cancer at the apex with an obstructing median lobe. So each one of those slices, they represents the center of the ultrasound element. So we are cutting, going head to foot, cutting in the prostate. So here we have the apex, and here we have the base. You see this median lobe protruding the bladder. The physician prescribed a treatment plan to spare the ejaculatory ducts. So you can see this boundary, this line falls short for where the ducts are located in here. And a median lobe that caused lower urinary tract symptoms was included in the plan. Here we can see the areas that achieved lethal temperature and complete ablation of the prostate cancer lesion, as well as the obstructing median lobe immediately after treatment. Next case study, it's a whole gland ablation of a patient with intermediate risk prostate cancer involving the proximal seminal vesicles. So when that's possible, some physicians have included that in the plan. So you can see that the prostate has been completely ablated. The seminal vesicles, the right seminal vesicles that had some invasion in there were targeted and successfully ablated. We can see the confirmation of the non-enhancing zone. So these areas in black has undergone an immediate thermocoagulation on post-contrast enhanced images. The last case study is showing the customized planning for an apical lesion. So one of the features of our software is that the physician is able to design a treatment plan, setting a target less than 14 millimeters to use the high frequency sonication, which gives a shallower penetration depth to protract the sphincter and the pelvic floor and preserve continence. So this patient's urinary sphincters right here, very low. You can see just muscles coming through this side. And the physician designed a treatment plan to be able to give appropriate clinical margins for the lesion that was just above this slicing here. So this is what he planned. This is the thermal dose he achieved. So this sphincter muscles coming from the sides were completely intact, and this patient did very well on his follow-up using this approach. So here I have a case of an ablation of an extreme size prostate. So it's a 214 cc's prostate. So the patient has a massive transition zone in here, was included in the plan. You can see the ultrasound applicator sweeping through the prostate. We do have sparing of the ejaculatory ducts. So as you see, the boundary kind of offshorts in here, the areas where the ejaculatory ducts are being performed, and a nice example showing the flexibility of TULSA on treating those very large glands. So in summary, the MRI-guided transurethral ultrasound ablation of the prostate, TULSA, is capable of both focal and whole gland ablation. Because we're in the urethra, is a transurethral approach. We can ablate both anterior and posterior lesions in small and large prostates. We have a favorable safety and quality of life profile in studies with whole gland, which was our TACT trial. We do have a low rate of residual disease in studies mandating rigorous biopsy. So was what I was talking about, those 10 cores in a 3 cc gland. Durable biopsy and PSA outcomes, we've seen it up to 3 years. We have a low rate of salvage treatment without limiting options. You do see when those patients do fail TULSA, and we saw 13% of patients had an additional treatment. There are reports of a successful radical prostatectomy afterwards. The patients can have radiation therapy. The patients can have a second TULSA, as well as other forms of ablation. So it doesn't burn any bridges. There is some promising preliminary data on the salvage setting for local radio recurrence, as well as combined treatment of cancer and benign prostatic hyperplasia. We've started our randomized trial where we are comparing TULSA against radical prostatectomy, which then we hope to obtain our level 1 evidence afterwards. And that's all for me. I'll take any questions.
Amanda.
Yes.
Hey, this is Tony Mentor. Quick question for you. I want to make sure I understand correctly this process. So this probe is put into the urethra.
Yes.
And the ablation happens from the urethra and it works its way around the prostate.
Exactly.
So how does that, or what happens to prevent any damage to the urethra as this power is powerful enough to kill prostate cancer cells?
That's a good question. So we have a cooling system. So inside this ultrasound applicator, we have a water channel that's circulating water during the entire procedure. So as we are ablating, we have water circulating, which gives us 2 to 2 millimeters of protection of any tissue against that ultrasound applicator. We also have a cooling of the rectum, so we don't have any energy coming from the rectum, but we have water circulating from that rectal device. You can see in here, which also provides additional protection to the rectal wall. So you can see here the water comes into the ultrasound applicator, circulates, cools the tissue that's immediately against the urethra, and yet being able to treat after that. Does that make sense?
Absolutely. And so post-treatment, there's no need for a catheter?
So there is still a need for a catheter, and the reason for that is because we are, thermally destroying that tissue. In the first 2 to 3 weeks, if you're doing a whole gland after the procedure, the prostate, the surroundings of the prostate is going to swell. And if the prostate swells and you don't have a catheter in place, then you're going to have narrowing of your urethra. So while the prostate swelling is going down, you do need to have a catheter in place. The more you treat, the longer you have the catheter. So if you have a whole gland treatment, typically you're going to look at 2 to 3 weeks. If it's a very focal treatment, you can be looking 5 days to 1 week. 1 week.
Okay.
Yeah.
I was just trying to get the picture of the whole process, because those are the kinds of questions that we get asked when we start talking about the different procedures, potential damage and the catheter, because those things are important when it comes to a treatment decision.
Absolutely.
Thank you.
Where can we go, or where can we send people to find out where the procedure can be done today? Who's doing it? I mean, I know it's supposed to be spread in years to come, but where is it being done today?
You can go to tulsaprocedure.com, and in that website, we have a treatment locator. So anyone can add their zip code and they'll be able to find what's the closest center to them.
Okay. And along with that, are you receiving referrals, or have you heard of referrals coming from the VA for the procedure?
Yes, actually, the procedure that I was just in now is at Yale Hospital, and they've had a patient from the VA that was treated in there. So that's a place for sure that I know is taking patients from the VA and receiving coverage, but other locations doing it as well. We've seen more and more patients from the VA receiving the TULSA procedure.
And are any of these installed in the VA yet? Are you doing procedures inside the VAs yet?
Not yet.
Okay. And another question, where does the process stand with CPT codes and CMS?
So we are applying for a CPT code. We have our meeting now in September for that code. We're expecting to get it in 2024. We do have a C code that we can apply for. So we see many patients getting reimbursed from that C code, but the CPT code, it's part of our strategy in the moment.
Okay. But you do have a C code. That's important.
Yes, so there is a C code we can use, yes.
Because we need to talk to, all of us need to talk to TriWest and to Optum about utilization of the C code in the community care network.
And we do have a reimbursement support email that I can share with you. So if anyone, wants to do the TULSA procedure and wants any help with that, we have a specialized team that can help in that process.
Okay, that'd be great.
Mm-hmm.
Yeah, we'd like to have that. And I think, honestly, what message does Profound or as Profound, what message would you like us to carry to the VA?
The message is that the TULSA procedure gives that option beyond standard of care, so you can have a good oncological outcome, but still preservation of safety. So we have really good numbers in terms of patients wearing pads, patients remaining in their potency. So look for a TULSA procedure, see if you're a candidate, because there is an option out there for preserving your safety and urinary and erectile function. And do reach out to a reimbursement support email and staff if you need any help, coming through the VA, and we can leverage our past experience with other patients to help.
Anybody else? Questions about it? Just as a reminder, the presentation that Amanda gave so articulately and explained the situation, and the briefing slides and her the meeting will be posted on the website, so you can refer people here if they have questions about it to the website, and they can hear the briefing, and they can also download the slides that Amanda's been using. So I appreciate it. We all do. Amanda, thank you for taking the time and it's an exciting technology. I know you're doing some great work for men, and it's just another option that we have out there to treat, for the prostate cancer issues that are going on.
Absolutely, my pleasure. Thanks for inviting us.
Yeah, absolutely. Okay, I think that's about it for everybody tonight, and thanks for everybody for your participation. I'm looking at questions. Tom, what's the process for joining you in San Diego? I'll give you a call tomorrow, and you're signed up. Okay. Yeah, that's an easy one. We can answer that easy. Anybody else? Ray, how you doing? Thumbs up. All right. Joe? Yes, sir. You had an update, Joe, I think from, you had a task, you and Tony had a task last week or last month.
Yeah, I got it. Well, we didn't really get together, but I want to see if I can organize something with him. I'm not sure I have his email, and if there's anybody else that wants to get involved in the initial stages of doing the support group that we're going to create. And the support group, as I mentioned before, it's just so everybody's aware, it's not intended to be a replacement for the regular procedural support groups, but more a matter of finding your way around the VA. Things like we came up with tonight, otherwise issues, sources of information, as well as routing things to other more technical support groups. We're doing this. I'm with ANCAM, but I'm also VP. So it's a joint effort that we're going to create, and we'll we can provide more information a little bit along the way. But it's one of those things where we all know the biggest problem that most guys have after they figure out they want to do something is how do I find it in the VA? How do I, the VA is a great organization. Just how do I get through it?
Yeah, right. Yeah. And we've always said that's the key, is that if you know the roadmap, it's the best healthcare out there. The problem is knowing the roadmap, right? And how to get. But
also, I would suggest also having the spouse or partner go with the veteran.
Yeah. Yeah.
And
absolutely.
Ray, the group that I'm creating for our mutual use, it also allows for and expects that the spouse, partner, or others who are involved can come on in. And it's going to be basically anything and everything that might be, the kinds of things that you need. And then the object is to either have folks within the group who already have some expertise or knowledge. Like I got one or two guys that are interested in coming in who happen to have just retired out of the VA. And they said, well, we might be able to teach you some of the ways to get through. And so it'll be that kind of program. And then if something says, well, now I really, I want to get a TULSA Pro done, we'll be able then to either route them to that or to other support groups. I think Tony, you have a support group, right? Where is he? It's not on. Not right. I didn't see him.
No, he's here. Actually, I think you're thinking of Harry DePolar has got a support group in Washington, D.C.
Oh, that's who it was
that they've held. Yeah, so Harry's running they've had a combat action support group in DC's VA. I think they're coming back to their first in-person meeting next month, but they've brought prostate cancer into the middle of that combat action group. It started out at Vietnam vets, and now it's gone to Iraq and Afghanistan, and now we're bringing prostate cancer into the whole thing as well. As he said, 80% of the guys that come to the meeting have got prostate cancer. So,
well, if he wants to get a hold of me, or I can get a hold of him, we got to, since this is the first time anybody's ever tried to do this, we need to be able to smooth it out, and make it fit.
Yeah.
But, I've already, from the technical support groups that I'm involved with now, I've got a number of guys that are saying, I'd like to help be a moderator. Somebody else comes in and says, well, I just want to be an information source, and that's great,
Okay.
And initially we're going to set it up for the fourth Thursday of the month And then depending on how the volume goes, we'll do more.
Okay. That's great. We'll advertise it and get guys to show up. So we appreciate it. That's good. That's good stuff.
Yeah, anybody and every, we take all sorts of input. If somebody doesn't want to necessarily commit, but's got lots of good ideas, that's perfect too.
Okay. Awesome. All right. Anybody else? Last call. All right. Thanks, everybody. You guys have a good week, and we'll be in touch, and stay tuned. A lot of things happening, and we'll see you in August.
Alrighty.
Yeah.
Take care.
Bye.
Sounds good.